Esther Calbo. I'm an ID in a general hospital in Terrassa, close to Barcelona. I've led the antimicrobial stewardship program in my own hospital since 2013, more or less. And I've worked with quality indicators in antimicrobial stewardship programs, mainly in general population, in hospital patients, and with outpatients as well.
Yes, I'm Antonios Katsounas. I'm an ID specialist and ICU specialist. I lead the department of clinical infectious diseases and internal clinical care at the Knappschaft Kliniken University Hospital in Bochum, Germany. And I have this position since 2020. So special focus is in patients with end-stage diseases like end-stage liver disease or end-stage pancreas disease, renal disease or lung disease, and with severe infections. We have a good cooperation with the National Reference Center for Resistant Gram-negative Bacteria, Professor Gattermann, who is also located at the same university, Ruhr University Bochum.
Yeah, when we started to discuss how to approach this meet the expert session, we thought that probably the best way to start is just showing that an infectious disease is not a binary scenario, in the sense that the patient at the end is not died or alive. And patients that can survive this process may present many different situations. They can cure rapidly or experience a recurrency or a readmission or many sequelae, or well, and all these scenarios needs to be approached, no? And this is from the point of view of what we can measure when we measure the use of antimicrobials in a specific syndrome. But we also can decide to study or to analyze how we use antibiotics. And this is more related to the prescribing process. And this also has many tools to use to measure beyond mortality. So mortality is a part of this story, not the whole picture. And probably we need endpoints that are broad and that include safety, patient experience, and all the possible results that the disease can present in general population and in ICU.
Yes, exactly. Mortality is a hard endpoint, but that cannot cover the whole spectrum of good clinical decisions when we apply antibiotic stewardship. So a good antimicrobial outcome alone, or clinical outcome alone, does not tell the whole story. And there are some, for instance, for the ICU population, there are some alternative endpoints which are equally important, which, however, clinical practice and clinical research does not very intensively focus on. We can address composite outcomes that include adverse effects, for instance, as Esther said, that apply to the treatment safety that has to be guaranteed, and of course to take some ecological issues into account. For instance, if you generate or not generate antimicrobial resistance on a population level, but also on an individual patient level. And how can you imply biomarkers to guide therapy? And also, in order to reduce, of course, the antibiotic days. And if there are some metrics that are appropriate to measure the antimicrobial stewardship interventions. And this is something that is being more accurately illustrated in studies that have been made for patients on the regular care wards That's why I would like to pass the word to you now.
Like door and radar are different ways to assess the results of an antimicrobial therapy using a rank that classifies the most desirable result for the patient. That means the best possibilities he is alive or she is alive, and the last or the bad one is to be dead. And in the middle, you have many possible situations that include safety and clinical efficacy. So the door and radar uses a methodology where you rank the many possibilities of the result of an intervention. So the patient can be alive and this is the best situation, or can be dead and is the bad one. And in the middle, you can have 1 or 2 or 3 events related to safety or clinical cure. And the patient can participate in the design of this outcome. So by this system, you can include the perspective of patients into the design of the outcomes, and that can help afterwards, when you have the results of the study, to use this information to choose which therapy is most appropriate for this profile of patients that maybe want to avoid adverse events, or will prefer a rapid clinical cure. So there is a lot of information there that can help us to include the patient in the decision making. If you're a young person, probably what you want with a treatment is a rapid cure, with no adverse events. With any adverse events, no matter what. The thing is that I will come back to my work in 2 days, even if I have diarrhea or I have something else that the antibiotic has produced. In the other hand, if you are a very old comorbid patient, you don't want any adverse event that can worsen your comorbidities. So this is the way that you can use this information to decide with a particular patient which kind of antibiotics for equal clinical cure. They are the same from the clinical cure point of view, but are not the same for the perspective of the patient.
Imagine you have a patient with lung cancer and end-stage disease, and as expected, the person develops pneumonia. Pneumonia can and requires, especially in the ICU, and especially if you want to avoid ventilation, this requires antibiotic treatment. It is more than debatable to which degree the antibiotic treatment may lead to a more stable clinical condition, and which percentage of this situation goes to the account of the underlying disease or on the pneumonia. So people who are not intubated, not ventilated, may co-decide the intermediate endpoints. In simple words, buy some time to take care of open issues, or there is also in intubated and ventilated patients, there are some intermediate endpoints that are very, very worth to be taken into account, like how many ventilator-free days do I have? How many antibiotic-free days do I generate? For me, the worst situation is a ventilated patient, day 28 or 30, and 0 antibiotic-free days, and no getting better. Because you have no clinical reason to de-escalate, and you have no hope to move in another direction. So these outcomes that can also help us assess how hopeful or despaired a situation is, should be addressed, more standardized in scientific research.
I think we are learning about what we want to measure. and the design of the studies. So one thing is to put a new antibiotic in the scenario, and you need clinical efficacy there, and that's a point, and that it's part of the picture, but not the whole picture. So, in my opinion, probably we have been focused on efficacy studies until now, mostly. And then we need a kind of design that is more clinical cure approach. We are learning, I think, that we need different studies for antimicrobial stewardships. And we are sensitive to the patient opinion in many scenarios in general in medicine, and also in the world of antimicrobial use. So these new endpoints or this new approach opens our mind, I think, just to see the whole picture from other points of view. And I think we are at the beginning of this way learning how to use them, how to design them, how to make patients to participate in this design, and how to use the results, because many of them are not hard outcomes. They are probably with many potential bias in the design, so we have to learn how to design, how to interpret, and to use them in real world. And that was, I think, that made the meet of the expert really interesting for the audience and for us, because we discussed a lot before, and I think we have learned, at least me, and it has been nice.
I fully agree, and I want to add, it's not only why mortality is not enough. It's not the only question. Mortality is not, on the ICU setting, is not the right outcome, because you have, the most of the times as a doctor, you treat people with an underlying disease. So mortality is not only linked to infection, because when you achieve day 7 or day 10 on the ICU, you are at serious risk to develop an infection and ventilator-associated pneumonia, for instance. So, but you still have your underlying disease, which is definitely not getting better for you, getting through you to get the infection. So this is one part. The second reason is the statistical limitations that mortality brings in such research attempts. Because you need much more people that die so that your studies have power. And it's, thank God you don't have it. That's why this underpowering in terms of mortality makes mortality not as solid as it's been declared for evaluating what you're doing. Palliative care, of course, it's there, but palliative care is not everywhere available. And palliative care does not exclude automatically intubation, and does not exclude automatically antibiotic therapy. Because somebody says, okay, we have lung cancer or you have liver cancer, but under normal conditions, you still have 1 year or 1 month to live. Who is the one who's going to say it's not worth adding 1 day or 2? The condition of the patient, it does that make us think if we should do this, if the potential benefit lies over the potential harm. And medicine is statistics. So you just have to develop a good conscience to take that decision. For instance, the ICU is a bit easier because we don't need to prove we have a critical situation. And the perspective I personally see is to discuss the potential limitation of non-applying antibiotics if clinical improvement is not there. Because microbiological cure, we reach it at the most of the cases. I think a question that came up was a question what we received online, if there is clinical cure without having microbiological cure. And of course there is, but concrete example, you have Clostridium difficile infection, and after you get your vancomycin or oral regimen, you have no diarrhea. And if you have no diarrhea over 48 hours, then this is a clinical cure. If you make the mistake, test the feces, you're still gonna find that on a DNA basis or on a protein basis that you still have an infection. So this is not the scenario that the microbe survives and the clinic ceases. It's only the consequence of the limitations of our tests. Yeah, and we still treat patients. We don't treat bugs.
Or samples.
Yeah. The question that came up yesterday was, after reflecting upon the session, was what if the title would sound, what if only mortality mattered? And this would make antibiotic stewardship meaningless, because you would apply everything, yeah, and you would only care if the patient survives or not, and not make any thoughts about in what condition. And I hope Esther agrees.
Yes.
The post-COVID era is an era that sets us in confrontation with long-term problems, and sepsis and antibiotic stewardship and application of antibiotics in whatever regime and order may still be associated with long-term deficits. So quality of care, quality of life is something that should also be assessed even if the infection is treated, because it has to do with antibiotic, and in this situation also with antibiotic stewardship.